Production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Payne Fund, and the United Black Fund of Greater Cleveland, Incorporated.
Love that. Good afternoon and welcome to the City Club of Cleveland. I'm Dr. Randy Siebel, Director of the Metro Health Case Western Reserve University Center for Healthcare Research and Policy and Chief Medical Officer for Better Health Partnership. And I, of course, am a proud City Club member. It's my personal pleasure to welcome today's speaker, the co-founder and CEO of Aledade Incorporated, Dr. Farzad Mostashari. The U.S. spends far more on health care than any other country and yet ranks at the very bottom of the 12th wealthiest industrialized nations. According to a recent report, in 2016, the United States spent $3.2 trillion on health care, or 17% of the gross national product. A major component of the Affordable Care Act was to change the way hospitals and physicians are paid, moving from a fee-for-service model based on volume of services delivered to an outcomes-based model based on value. The goal of this value-based care model is what we call the triple aim: better care, leading to better health, and lower per capita costs of care. Although there is bipartisan support for the value-based care, under President Trump and the Congress, as we all know, the future of ACA is uncertain. Given that, what is the future of health value-based care? How can hospitals and physicians use technology infrastructure, including electronic medical records and health information exchange, to ensure the best outcomes for patients while reducing costs? And how can primary care physicians assume their inherent leadership in patient-centered care, not volume-based care that results in unnecessary testing and treatments? It's within this context, that our speaker joins us today. Dr. Mostashari has spent his career at the intersection of healthcare policy and health information technology. As the National Coordinator of Health Information Technology from 2011 to 2013, he coordinated efforts to build health IT infrastructure for healthcare reform and was the Chief Health IT spokesperson for the United States. He also led the implementation of the HITECH Act, which provided federal funds that enabled our hospitals and community health centers to purchase and implement their electronic health records, for which we should all be grateful. As co-founder and CEO of Aledade, the software he developed has a dual purpose to achieve the triple aim, again, better care, better health, and lower costs, while simultaneously saving the primary care physician and patient-centered care. Prior to his work in the Office of the National Coordinator, he founded New York City's Primary Care Information Project, which equipped 1,500 physicians in underserved communities with electronic health records. He's spoken and written extensively on accountable care organizations, health policy, and health care delivery. He's published in the New England Journal, in the New York Times, the Journal of the American Medical Association, Health Affairs, among others, too numerous to count. After winning a silver medal in the U.S. rowing nationals while at Harvard, seriously, trying to bring him back, while at Harvard, Farzad received his medical degree at Yale, a good decision, and his master's in population sciences, a good decision, from Harvard T.H. Chan School of Public Health. Ladies and gentlemen, members and friends of the City Club of Cleveland, please join me in welcoming Dr. Farzad Mostashari.
Thank you so much. Thank you for the City Club. Thanks for all of you for having me. Thanks, Randy, and the Better Health Partnership. I really appreciate the opportunity to speak to you today. That is the first time anyone has brought up my rowing career on an introduction. So my mother thanks you. And let me start with my mom. A 75-year-old's heart can't beat at 240 times a minute very well. At 240 beats a minute, there isn't enough time for that heart to fill and pump blood effectively. So when a heart goes into ventricular tachycardia, no blood is being pumped, and if it goes on too long, the patient expires. My mom was having runs of ventricular tachycardia while in the hospital. She had gone in for a routine knee replacement. She was pretty healthy. She was taking an aspirin. For a 75-year-old, not bad. But her knee hurt, and like so many other seniors that we know and love, she went in to get this very common procedure, a knee replacement. Let me ask you, I was a data guy. I was running health data for the city of New York. I assumed I would be able to find out where the best place is to get a knee done. Where's the best place to get a knee in Cleveland? Who's the best surgeon? Who's got the lowest complication rates? How would you know? So 7 years ago, to my shock, there was no database to go and find who has the lowest redo rates, lowest complication rates, the lowest surgical complications or infectious complications. That data is there, but it's not available to patients and their families when they want to make the best choice. So we went with, I trained there, I knew people, so we got, the best academic knee guy. Well, actually, it turns out he was doing shoulder research, but, he does knees too. And she showed up, and there was a surgical checklist. Atul Gawande must have gotten there to them. And on that surgical checklist, while the surgical team is getting introduced to each other for the first time, hello, that's part of the checklist. Introduce yourself to each other, because odds are you've never worked with each other before. Fellow, anesthesiologist, the nurse, right? The anesthesiologist running through the checklist, my mom said, so, and you stopped the aspirin, right? 7 days ago, you stopped the aspirin, right? Because that's what you're supposed to do for surgery. That's the system. The system is you ask the patient on the day of surgery whether they stopped the aspirin 7 days ago. Anyone strike that as being funny to anyone? So she said, well, no, she's 75. She didn't grow up in this country. Somewhere in that stack of papers, I'm sure someone had told her, right? She's a non-adherent patient because she didn't have skin in the game, apparently, enough to really take accountability for stopping the aspirin 7 days before. So what are they going to do? It's the first case of the day. Someone said it's like a, F-16 on a aircraft carrier, right? That time is very precious. We're not going to waste that time. So, we have the best surgeons, we have the best fellows, we have the best medical students, the best nurses, right? So of course, we're going to go ahead. We can handle this. And like 1 out of every 3 Medicare patients who goes into the hospital, she had a complication. She had actually many complications. She had a bleeding complication. Then she had an infectious complication. And then she started having runs of ventricular tachycardia. 16 beats, 18 beats, 24 beats. And I want to help my mom. So I'm there in the hospital. I don't go home. And I want to help. And it's 3 in the morning, and she's having longer and longer runs. And I am petrified. I'm a doctor. I'd been behind those same desks many, many times, but it feels different, doesn't it? When you're on the other side? It felt a lot different to me. And I wanted to see what the cardiologist had written in the chart. Anyone asked for a medical record in a hospital? Anyone had that experience? Right? As doctors, we walk back, we pull those gray things, right? We pulled them out, slip through it, right? We own the place. You're a patient. Worse yet, you're a patient's family member. And you say, can I take a look at the chart? What's the body language we give patients when they ask that? Is it like, of course you should see your chart? well, of course you want to help. It's your mom. It's her life. Of course you should see the chart. I'm so sorry we didn't make it super easy for you to read every day the notes and get explanations of what these things mean. Not quite. All right, because why? That paper chart is what economists call rivalrous. I have it, you don't. Goes with the patient down to get the CAT scan. We don't know what's going on with the patient. There's no chart. Oh, it's down. We lost the chart. Right? So finally, I screw up my courage. I'm like, hey, can I please see it? And the body language is all like, why? You gonna sue us? Right. I'm like, well, I wasn't up until this second. Or like, what, you want to get a second opinion? You don't trust us? So I flip to the page, finally get it, flip to the page where the cardiologist note is. It's a short note, it's about this high. The handwriting is curved and slanted. But that's about as much as I can understand from the writing of that cardiology attending. I literally could not decipher what that note said from the handwriting. And here's the kicker. I couldn't make out the beeper number. That's real skill. That person has been in attending for a long time. If you can't read the beeper number, there must be something special. And of course, she leaves the hospital after this long stay. There's all sorts of things. They find, an incidental, gallstone that should be taken care of as an outpatient. And of course, she leaves the hospital eventually, spends weeks. I don't think her primary care doc visited her. I don't think her primary care doc knew what was going on with her. I don't think anyone was in charge, right? And she goes home and, outpatient follow-up for that. Remember that gallstone? Well, yeah, a year later, she had emergency surgery because she got gallstone pancreatitis because it was never followed up because there was no one in charge. So what do we have? We have a system where you can't know who to pick. You don't know who's got any transparency for something basic as this. The system is you ask the patient the day of the surgery. How hard would it have been to, had a system where there's a reminder call 7 days before? Like, you don't have to be a genius to figure that out. Right? This is one of the world's most elite institutions. Somehow we couldn't figure that system out. Right? We can do bone marrow transplants, but we can't call a patient 7 days before the surgery. The charts on paper, can't read it. The Patients are not part of the care team. There's no outpatient follow-up. Other than that, American healthcare is the best in the world. And every single patient who touches her, right? Every single person feels bad. We take extraordinary people. We take amazingly skilled, talented, hardworking, compassionate, caring people, and we make them feel bad every single day for having failed their patients, where in fact it was the systems or lack of systems that failed them. Systems are what take ordinary people, and they can accomplish extraordinary things with systems. And we take extraordinary people, and we get very ordinary results because of a lack of focus on systems. Every single time we ask people to make up for that. People, human beings, have to be the safety net always. And when we fail, it's our failure. In medicine, it's not true that victory has 1,000 fathers and failure is an orphan. In medicine, it's exactly the opposite. Every failure has 1,000 people who feel like they did it. You've been there, right? I almost killed a person in residency. It wasn't me. There was no systemness to it. Now, all this was ironic because here I was in the hospital calling David Blumenthal, the incoming national coordinator for health information technology, to say I'm going to be late, boss, to start my new job in Washington because I'm in the hospital with my mom. And it's ironic because I had spent the past few years, as Randy mentioned, trying to create more systemness for healthcare as part using electronic health records as a way, not for the sake of making it digital, right? Tom Frieden recently said, I was cleaning up my office when he was leaving CDC, and he said, I found this piece of paper on it. And on the piece of paper, it said, Farzad says EHR is just an excuse to rework workflows. I'm like, yeah, that's pretty much right. That's pretty much right. We'd come from New York City. It was just an amazing time and place to be, mostly because we had a mayor, Mike Bloomberg, and a commissioner, Tom Frieden, who knew what question to ask. And this is, in the world of data, this is oftentimes underestimated. What's the question you're asking? What's the question? What's the question that the board, your board, discusses every day? Every time the board meets, what's the question that we ask? You know what question Mike Bloomberg asked of Tom Frieden, Commissioner of Health of the City of New York? You know what question he asked? What would you ask if you were the mayor and you want to ask the Commissioner of Health? What's the question you would ask him? I'm comfortable with silences. What question?
Why is our value so poor?
Why is our value? Yeah, I mean, that's a question. Why? Yeah.
Spend. What's our spend?
What's our spend? That's a very common question. No? How do we what?
How do we keep people healthy?
How do we keep people healthy? Getting warmer. How do we keep people alive? How do we?
How are the children?
How are the children? The question that rings with the clarity for me was, how do we save the most lives? That's my job as mayor of a city. I'm going to ask the question, how do we save the most lives? So what was the answer? For City of New York, 2001, 2002, what was the answer? How do we save the most lives in the City of New York, 10 million people? What was the answer? Soda. Soda was not what the first thing we did, people. You have such short memories. Smoking. It was smoking. It was and remains the largest preventable public health killer in the country and in the world. And then it was like, okay, how do we save the most lives? Okay, we address smoking, and then what do we do about smoking? And it was like, we do everything, right? We cut teen smoking from 14% to 7% in 4 years. Adult smoking had been rock steady at 22%, and then it started to trend downwards. We raised the tax. We raised the tax again. If we could have, we would have raised it again, but we couldn't. So instead, we banned smoking in bars and restaurants in New York City, which was a freaking unusual thing to propose at that time. We did marketing, we did advertising, we did address smuggling, we did everything. And then the question got flipped to me. I was there, I was helping support these efforts. And then Tom said, you know, there's this article that came out that found that in the past 10 years, 1990 to 2000, of all the lives saved from heart disease, which is the biggest killer, half of those lives saved were from public health and structural interventions like less smoking and so forth. Half of the lives saved was from medical care. Wow. And he said, well, what can medical care do to save the most lives? Because, you know, at that time in public health, that was actually kind of an unusual thought, right? There's this graph on the cover of the New York City Vital Statistics report every year, and it's called The Conquest of Pestilence. I love that graph. And the Conquest of Pestilence shows death rates in the city. And they start really high, and they just, the slope is just downward, 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 and then there's spikes when there's plague and flu, and right, and they just come down, 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 and then it kind of flattens out. You know when that death rate flattened out? You know what year that was? When the death rate, when most of the decline in mortality had occurred in New York City? You know when that year was? 1945. Amazing. Yeah, that's right, Gene. 1945. And what was 1945? Was that like penicillin? Penicillin. It was before penicillin. So medicine had pretty much, for public health people, pretty much no role in saving lives. But something changed around 1980s, 90s, right? The medicines got better. And our ability to address chronic diseases got better. And then we could ask the question, what can healthcare do to save the most lives? And it turned out, I went to the literature to go and find out. There are hundreds of thousands of scientific articles published. It turns out there was not a single article that we could find that even tried to lay out a number that said, how many lives could we save if we did what? How can healthcare save the most lives? And that to me is the mind-blowing thing, because a lot of us here work in healthcare, and I would ask you, when was the last time at your board meeting the board asked the question, how can we save the most lives? Not how much money are we spending, not what activities are we doing, but how do we save the most lives? When was the last time you had to answer to the board that question? So how can healthcare, how can your institutions save the most lives? Randy, don't answer. Sherry, you too. How can we save the most lives? Immunize. It's true, right? Herd immunity is a big thing. But to take us from where we are today, we're already kind of not bad, right? Less juice to be squeezed, to take our institution from where we are today to where we know the best institutions can be. It's not immunizations. A lot of times, diet. Turns out we don't know what to do. If we could, like the best institutions in medicine and healthcare don't know what to do. Don't have effective interventions.
Eliminate errors and mistakes.
Don't kill people. And that's a good start, The way we can save the most lives is not to kill people.
Coordinate medical homes for patients.
Call your patient 7 days before.
Yeah. Right, that goes with the don't kill people. So it turns out that it's blood pressure control. And I read this interesting article in the New England Journal. I don't know, when was that, Randy? 2009? 2009, I read this interesting article in the New England Journal when I joined the health IT mission. And with this article, it was out of Cleveland, I think. And what this article said was that groups that were using as part of a quality improvement project, they were all part of a quality improvement project. But the groups, those in the group that were using electronic health records did a much better job than those who were using paper, and they were improving faster. And that, to me, was the key. Not only were they better, but they were improving faster. So that, to me, was, thank you, Randy, for that work, and thanks for Better Health Partnership for continuing that mission. So that is, right, better control of blood pressure. We're at 55% nationally. We're at 72% in this area, which is an amazing accomplishment, but we can be better. And if your board's asking you ever, how do we save the most lives, it would be, let's focus on blood pressure control. But here's the thing. Here's the tough thing. We said, okay, we're not just going to pay for pianos, like buying electronic health records. They've got to be usable for like controlling blood pressure. So what do? You got to collect the blood pressure in a standard way, which people weren't doing before. You got to know what meds they're on. So we don't need 5 different ways of representing medications. There's to be one way of representing medications. Allergies we got to document, and then we got to document patients' diagnoses, not 12 different ways, but one way. And that became, this list of stuff you got to do became the framework for what do you got to do to earn an incentive payment. What's the problem with that? Check, 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 check the box. So we got a whole lot of systems in place, and I am grateful for the opportunity to have done that, but we also got a whole lot of box checking. Check the box to get the check. And what are doctors sick of right now? Box checking. Box checking. And it seems like every time we want to change the healthcare system, there's a whole new bunch of boxes to check. An insurer wants to address the opioid crisis. Well, why don't we create a prior authorization? And that way, if you want to do that, you got to check a bunch of boxes. Because you see, it's unpleasant to check boxes. It takes more work, so we'll get less of this. And we want more of that thing. Let's get them to check some more boxes and jump through some more hoops and put a coin in. You want them to do something, feed the slot. Put in a quarter to get some action. Why do we have so much administrivia? Why? Because it's all we know how to do with the incentives that we're in. Why do health plans? Not that they're bad people, right? They're trying to control costs, right? We have to control costs. So what do we have to do? We have to make sure that people don't get unnecessary tests, and that we do some rewards for pay for performance, and we'll sprinkle a little bit of this on it and a little bit of that on it. And we're not seeing something. It's like we're almost in it, but we can't see it. It's invisible. It's like these two fish, right? That they were swimming along one nice cool morning, and this frog jumps in next to them. And the frog says, "Good morning, boys." Frogs are weird. And says, "How's the water?" And the fish like look at each other. If they had shoulders, they'd shrug. And they don't say anything. They just swim by this weird frog. And then one of them turns to the other and says, "Hey, Frank, what's water?" Our payment system is the water that we're in, that we're not seeing. It's like it permeates absolutely everything in healthcare. Because, we all know that healthcare is not about money. And healthcare is always about money. You don't get to be 17% of the economy and not be about money to some extent. So what are the incentives? My mom's hospital stay, did the hospital get paid more or less for that lack of system?
Did they get penalized for the infection?
They got paid a lot more. 7 years ago, there was no penalty for the infection or penalty for complication, right? So as long as it's not that anyone's a bad person, or we're trying as hard as we can here, but are we going to invest, is the CFO going to invest this chunk of change on creating new systems for this, whereas the return on investment as a fiduciary to the hospital must be in increasing our, whatever, get another proton beam. It just makes sense. It just makes sense. You can't fault the people in the system for acting in the way that the system is incentivizing you to act. And that I spent 20 years trying to do that. I spent 20 years trying to get people in the system to act against their interests. And I was like, wait a minute. What if we actually find an area where I don't have to constantly be swimming against that tide? What if we imagine if there was a part of American healthcare, if there was a way, if there was a payment model and a delivery model where we are aligned between what's good for society and good for the patient and good for the doc. Imagine what we would do differently. And that's what we have. That's what value-based care means. Value-based care means imagine if you, the doc, had the same incentives as the health plan. Imagine if the total cost of care is what you cared about, not your piece of it. Imagine what you would do differently. Imagine the prevention you would do. Imagine that you would care about the blood pressure, not because the system told you, or there's a pay-for-performance, or there's a quality improvement project, but because it's good business to care about blood pressure and the immunizations. What if it made sense economically to call the patient 7 days before and read the notes after the patient gets out of the hospital, and call the patient the day they get out of the hospital? What if that just made sense? What if you called the patients, some patients who really need it, not when they're coming into the office, but when they're sitting at home, if they really need it, and just check in with them, see how they're doing, because you're worried about them? What if you cared about where you send that referral, not based on what system they're in, or who you play golf with, or who writes you a nice note, but actually who has the lowest complication rates, who has the best value, who treats the patient the best, who does evidence-based medicine? Imagine that world, and let's go build it for Mom. Thank you.
Hello again, I'm Dan Moulthrop. Today we are enjoying a forum with Dr. Farzad Mostashari, co-founder and CEO at Aledade Incorporated and the former national coordinator for health information technology in the United States Department of Health and Human Services, also a silver medal. No, I'm just kidding. We're about to begin the audience Q&A. We welcome questions from all of you, including City Club members, guests, students, and those of you joining us via our webcast or our live simulcast at the Jack Joseph and Morton Humanities Center at Cuyahoga Community College. If you'd like to tweet a question, please tweet it at the City Club, and our staff will work it into the program. Holding our microphones today are Membership and Customer Service Manager Corey Isler and Content Coordinator Bliss Davis. May we have our first question, please? If nobody, we can be comfortable with silence, or I can ask one too. There we go.
Thank you. Please stand. Oh, I don't take instruction well, apparently. It was a pleasure. Thank you for your presentation. You mentioned when you were with New York, with the city, that the question was asked and it was smoking. So that's a focal point in terms of addressing much larger issues. So that said, converting to a value-based system, what would be the one thing that you would start with in order to establish that and give it traction?
In the value-based world, you don't have to worry about 20 different measures and metrics. There's really just two, right? One is total cost of care. The total cost of care, right? We don't have to make, we don't be like, oh, we don't want to pay primary care docs, 1% more if they do these things or whatever. It's just, how do we reduce total cost of care? How do we focus on total cost of care? Now, under that, right, and with smoking too, it was like, okay, now that's our big goal. What are our strategies? And our strategies devolved, right, into tax and regulations and so forth. And similarly with total cost of care, you're like, okay, we got to look at every single piece of this and see where is there care that is not good for mom, that we can, no one wants to be hospitalized, right? So how do we reduce hospitalizations? How do we reduce unnecessary ER visits? How do we reduce unnecessary stays in nursing homes? How do we get people out in a more coordinated way so they stay there less? So that's the one thing, is total cost of care, and everything else is oriented around that. So we don't have to say to people give pneumonia shots. Well, of course I'm going to give pneumonia shots because that's going to prevent grandma from having pneumonia from going to the hospital. Of course I'm going to do that. The second thing, though, which is really important, is people can't. The reason why managed care failed 20 years ago was because policymakers, the public, got the feeling that the only job of the primary care doctor here was as a gatekeeper. And that's not what people want to be. It's not like, I'm really proud to be denying people needed care. No one feels good about that. So if we want to make this sustained, the second thing has to be, it has to meet the test. Would you want it for mom, right? Is this more? Is this better, right? So the second thing we focus on is this better for mom? So those are the two things. Is it reducing total cost of care, and is it better for mom?
Thanks for coming. In addition to knowing something about the chart, should the patient have any idea of what the procedure or the hospital stay will cost? And would that make a difference in maybe putting some pressure on costs of medical care?
Yeah. My mom has also diabetes-related macular degeneration now. So there's an injection that is really saves people's vision. I mean, it's amazing, right? So she's getting these injections, and there's two formulations of this medicine. That was initially a cancer drug, and you can get it in a big vial, and it costs $50, or you can get it in a little vial, and it costs $2,000. Same drug, same manufacturer. Little vial, $2,000. Big vial, $50. And I said to her, next time you go to the doctor, ask for the cheap one. And she said, if it's more expensive, it should be better. And I said, no, it's not. Trust me. Right? She's like, nope. I want the more expensive one. And I said, Mom, if you had to pay, I don't know, $300 extra to pay 10% of that difference in price, would you choose? She was like, it's your eyesight. I mean, you don't take risks with your eyesight. And I said, if you had to pay 10% of that, would you go for the more expensive one? And before she can answer, my dad yells out, she's lying if she said she'd take it. Of course it would matter to her, right? So I do think that, of course, one of the roles of what a partnership between an insurance company, a health plan, and provider group can be is to make alignment between the things the doc is telling the patient to do and what the patient sees in their interest. If I'm a doc and I'm telling the patient, go over here, and the patient's like, well, I don't want to go over there, that's uncomfortable. We don't like that. If we say, take this medicine because we want to control total cost of care, but it's the same price or cheaper for the patient to take this other medicine, then we're at odds with the patient. So getting alignment in that benefit design is really important. The key, though, is we can't just shift risk onto the people who can least afford to take that financial risk. And much of the policies, however well-intentioned, I think, around more skin in the game for patients are just shifting costs from whoever it is to the pay from the company or whatever. And that, there's a limit to how much we can do that on the kind of demand side of healthcare. We got to start looking at the supply side as well.
Hi, I'm Dave Margolis, primary care physician at Metro Health.
Yay, primary care.
And so we're...
What's your blood pressure control rate?
62%.
Oh.
Yeah, it's not good.
What are you going to focus on for the next month?
Yeah, so, I mean, this is so... I'm glad you... It's perfect. So,
how's your RVRU productivity, though?
It's really good because I do 4 weeks of inpatient a year, and I spread them out throughout, each quarter, and so all of a sudden I look like an amazing, productive primary care physician because it's really the RVUs from the inpatient work. And so that's actually my question. So we live in this world where right now we're about 3/4 fee-for-service, maybe a little bit more, and we've got about 1/4 to 1/3, in these value contracts. And I think, obviously hopefully the payers will continue to transition towards value. But as a middle manager myself and, working with other middle managers, it's really hard to figure out how to incentivize, reward, measure how well people are doing in the value world. The volume world, it's easy to count how many visits you do and our RVUs, but I'm 62%, but maybe that's because my patients are poorer and sicker and all that stuff that you hear from doctors. And so what are the tools for middle managers and others to measure and reward and work on performance?
Yeah. The mnemonic I have, and you're a doctor, so you love a mnemonic, is I decided to cha-cha. And the I is incentives. Make sure that they have some incentive that's aligned with this, right? Don't do this thing that we do where we're like, you got to work on this, but like how much they're paid is based all on RVUs, right? So align incentives. And this is one of the things that we hear over and over again is with our independent physician ACOs, they're mostly small practices. Every physician generally, if we get savings, they get that return. So that return goes shoop right to them. Larger organizations have to find ways of making sure that their incentive structure, their management structure reflects the organizational goals. If your organization is going to get after total cost of care, your physician compensation needs to reflect that as well. D is decide, which means don't pick too many things. You can't focus on 100 things. Focusing on 100 things means you're not focusing on anything. So 20 quality measures is probably too many, right? That's why we say 3 measures, right? So make sure that you focus that. T is for teams. It's not just the primary care doc. It's the team, right? It's the pharmacist. It's the nurse. It's the care manager. It's the front desk person. The whole team has to be embedded in this to make it easier. Because one of the things that we do wrong in medicine is we dump everything on the docs, right? It just makes no sense. And then you change. You got to actually change something. And this is the dirty secret of actually changing healthcare is you got to change. And I see a lot of organizations who are like, well, what have you changed? And they're like, we have monthly meetings. I'm like, wait, no, what have you changed? And they're like, we have monthly meetings. I'm like, that's not changed. The patient's life didn't change from that. And then you got to assess because, you never know, right? So change it in a way, track it, and then see if you got better improvement. Oh, sorry.
How do we address what I'll call the prescription dilemma, where you have prescriptions that may mask the disease versus actually reversing or treating it? Obviously, the cost associated with them, and if you hear prescription drug commercials these days, it's like, oh, it fixes, it solves this problem, but the side effects are almost as worse as whatever the condition you're treating is.
I mean, it's been interesting. I was just at a meeting with these pharma CEOs, and they were all like, oh yeah, we're going to do value-based pharma. I'm like, great, right? But it's got to be real, right? It's got to be real. So I think if you get, again, it seems like a shockingly simple solution is like people's incentives should be based on the total cost of care. If giving this medication is going to reduce a hospitalization, really, I will gladly give the medication, right? If it doesn't, then, I don't know.
We have a question from Twitter.
Hello, tweeps.
In a hypothetical single-payer future, is HHS capable of creating the kind of future you're talking about?
There's a lot of, between here and there, there's a lot that would have to happen. And one of the questions is, like, what does that really mean, single payer? Because there could be a world, a single payer, like Medicare Advantage, where, like, yeah, it's a single payer who sets the payment scale, but they don't have to get involved in the nitty-gritty of every single interaction and payment compensation model and benefit design or so forth. They lay out some guidelines and they let the private payers innovate around that. So I could see a world where that absolutely lines up. The key is to get alignment between the payers and the providers. To me, there's been, and we heard about like the ACA and so forth, that's still about the insurance markets. It's not as much about the delivery system.
Hi, Michelle Medina, I'm a primary care provider, and my combo 10 immunization rate is at 82%, so not doing badly. One of our
I heard that kids now have hypertension too?
Yes, came up with new AAP guidelines on actually our blood pressure guidelines. So we're trying to figure out a way to get that into our EMR so that it pings us the right sort of blood pressure norms.
That's scary to me, right? If we're starting to see hypertension moving into kids.
And Better Health had hypertension data in their last CHI obesity report.
Yeah.
Call out to Rita. Yeah.
Yeah. Head of the curve, Rita.
Head of the curve. So my question is, one of our chairs likes to cite a paper, and I'm not so sure where it came from, that to change behaviors for primary care folks, there's a certain proportion of their incentives as far as payer mixes, about 30%.
30%, I've
right,
heard that.
As far as value-based care.
Yeah.
So what's your perspective on that one? Is it real? Do you find that that's the experience?
Yeah, I think that's about right. I mean, the way I think about it is it's got to make a material difference to your economics. And, you can draw that line, like for one person, material means something different than the other, but 30% seems like pretty fair. If like you got a 30% either hit or raise, like that's significant. And for primary care, a lot less than a 30% hit is existential, right? You can't manage a 30% hit. So I actually think that there's good rationale for having asymmetric risk reward, particularly for primary care, where there's a percent of their rev is the model that we successfully got Medicare to adopt around Track 1+, which is 8%, up to 8% of their revenue is on downside risk, but they could double their income on the upside risk if they, knock it out of the park. The key there is getting more and more of the patient population under risk arrangements. And that's where we really have a little bit of work to do, right? So Medicare now, you can just apply, jump through 263 hoops. At the end of the day, you're in a program, right? Not saying it's easy, but it's predictable, right? We need to bring more on. We need to get the purchasers to be asking for it. We need to have the payers really pushing providers along into these more aligned arrangements. The state as employer, and obviously Medicaid, I hear good things, no promises, I'm told. But I think that there is progress in that direction of getting every payer aligned to the same kind of thinking.
Hi, thanks for your passion on these issues. Jean Polster from Neighborhood Family Practice, a health center on the west side. So what's the role of elected officials in the conversation?
Yeah. I think this is one area where, a MACRA, which pushes payment, it makes, it brings all those box checkings together in one place so you could see it, and it like freaks everybody out when they see all the box checking they were doing now in one place. But it also says your get out of jail card is advanced alternative payment models. That legislation passed. You know how many votes it got in the Senate? Anyone know? What are bills passing these days in the Senate? 51? No. 55, do I have 55 to 66? 60, 70, 80, 92. Macro got 92 votes in the Senate. 92 votes in the Senate. So this is one way, and I was talking to Real Politico, and they said, yeah, because they didn't know whether they should be for it or against it. Like, no one's told them, like, it's a Democrat thing, it's a Republican thing, it's a Libertarian. It's like, sounds good to me, better care at lower cost, I guess I'm for it, right? So I think that's the good thing we have going for us here, is that politicians should be supportive of getting more value for your money and improving care for mom. Is that too much to ask for? Maybe. We'll see.
Hi, I'm Mitch Wasserman. I'm not a clinician, and I don't play one on TV. My question is regarding the health plans available on the exchange.
Mm-hmm.
These plans have had a growing amount of cost sharing imposed on the insureds. Higher deductibles, higher co-insurance, co-pays. My observation is that these result in lower utilization of either necessary or unnecessary services. Is anyone thinking or looking at the quality of care that's being received by those folks on the exchange?
Understanding that aspect, like it is, as I said, cost sharing works to reduce cost, and not just on the exchanges, but if you look at employer plans, that's a go-to card that they're going to more and more and more and more and more, right? And you're right that their research does show that it reduces utilization of both necessary and unnecessary, which is why essential health benefits was created. That was the whole idea, is saying, let's keep and update a list of things that we don't want people to cut out, and then you get $0 copays on those, and they don't count. So that, I think, is the, it always happens. I mean, it's you're not shaming people enough. Just kidding. So I think that it is not a cost control measure that you can keep going to. You do need to work on other ways of reducing cost.
So through the experience with your mom, you mentioned the need for a remind system, right? So that type of stuff exists today. In your opinion, what's a system or a technology that can be more than just a box check and kind of really enable us in this VBC transformation moving forward?
I think Randy talked about the technology that we've built, and yeah, we have some great cloud-based tools that help do big data, risk scoring, predictive modeling, readmission, all that kind of stuff. But those are just tools, and you got to know what ladder you're climbing, like what's that ladder leaned up against, right? And so the key thing that I think we do for our docs is we actually give them entree into a new business model. And so it's the combination of a new business model plus new tools plus a whole ton of workflow redesign. Because you can't just be like, oh, I'm only going to change my business model and my technology, but my workflows are going to stay exactly the same, right? Like that's really the by far, I think there's too much attention on the tech and not enough attention on business model and workflow redesign.
Okay. Hello there. Thank you for coming, doctor. My question was, like you said about Bloomberg, mayor asking about what is the most, how to make people alive. But also, apart from preventing, there's a fact about behavioral health. How do you see it integrating with medical? And what are the new technologies, like I've heard recently about comprehensive electronic medical records? Like, is it possible, like, for
I
the
think
future?
if we change its name, it's going to be much better.
It's better. But yeah, that's my question.
So around behavior, and I'm gonna take the question maybe in a direction that you meant, maybe not. I actually think that one technology that we haven't tapped into nearly enough is the emerging understanding of behavioral economics. And free ways that just by doing it a little bit differently, we can nudge people into the right direction behaviorally, right? So all of us, like, we all like, I don't know, pick anything, even if you've sort of, no-show rates, right? No-shows, like, pretty much suck, right? We all agree on that? No-show sucks? Sucks to have a no-show? Anyone ever done an A/B trial of ways of reducing no-show rates? No? I would have thought you would have done it. No? Peter, come on. Gene? No. Why not? It's free, essentially free, right? Like, we don't have to spend more money on care coordinators or managers or technology. Like, why don't we test? Like, we have some theories now about what people do or don't respond to, right? Most people do show up. Like, let's test that message, right? Let's give a little loss aversion in there. Let's use some of these things that we now know about how we're all irrational, and let's stop pretending that you're rational, I'm rational, that the patient's rational, and let's try to nudge people into doing things that are better for them, right? And then let's do some testing around that. That to me is like a technology that like is just waiting there for someone to use in healthcare.
Thank you so much. That's great. Today at the City Club, we've been enjoying a forum with Dr. Farzad Mostashari, co-founder and CEO at Aledade, and the former National Coordinator for Health Information Technology in the U.S. Department of Health and Human Services. Dr. Mostashari appears as part of our Healthcare Innovation Series, which is sponsored by Cleveland Clinic, Medical Mutual of Ohio, and the Metro Health System. We appreciate your continued support of our programming. Today's forum is also the Medical Mutual of Ohio Endowed Forum on Healthcare, made possible by a generous gift from Medical Mutual of Ohio. We have several representatives with us today, and we thank you for being with us. Community partners for our forum today are the Better Health Partnership, the Center for Healthcare Research and Policy at Metro Health, and the Center for Health Affairs. Our hospitality partner is the Metropolitan at the 9 Hotel. We appreciate the partnership of all of your organizations. Additionally, we welcome guests at tables hosted by the Center for Community Solutions, the Centers for Families and Children, and the Centers for Families and Children. Also, we welcome students from North Olmsted High School. Student participation in City Club forums is provided by many foundations, including the William E. Weiss Foundation. We thank all of you for being here today. That brings us to the end of our forum, ladies and gentlemen. Thank you, Dr. Mostashari. Thank you, Better Health Partners, for helping us partnership for helping us organize this. And thank you all, ladies and gentlemen. Forum is adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
Production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Payne Fund, and the United Black Fund of Greater Cleveland, Incorporated.